Good morning in the United States and good evening in India and Myanmar. I'm a senior patron of the Myanmar GI&LiverFoundation, together with my colleagues and the president of the Myanmar GI&LiverFoundation and world-renowned top man in the field of NASH, Professor Arun Sanyal. We are organizing a webinar on the NASH, non-alcoholic steatohepatitis, to commemorate the International NASH Day. In fact, we have arranged a little bit in a rush and late to communicate with the GLI, Global Liver Institute, and we cannot use official logo of the GLI and the NASH, International NASH. In fact, yesterday, 12 June was the International NASH Day, and we want to arouse the awareness of the NASH throughout Myanmar and throughout the region, because our webinar is now watched by the people from Cambodia, Singapore, India, and other ASEAN countries as well. Particularly in the COVID-19 period, for example, in my country, there's about 3 months homestay. We have reduced physical activity, overeating, watching the TV, to read the books all the time is not possible. So that will favor again the progression of the existing fatty liver diseases. Therefore, it coincides with the International NASH Day, 12 June, and we have to arrange a webinar in commemoration of the NASH, together with my colleague, Professor Anil Arora, who was the president of the Indian National Association for the Liver Disease, and Professor Anil Arora was very active. During the last 1 month, he has organized so many webinars. So today, this event, myself and Anil will moderate together. Professor Anil Arora, could you say something?
Dr. Arun Sanyal, who is the pioneer in application of NASH. In fact, most of the pioneer work and the seminal work has been done from US, from his own center, and we are privileged to have a grand personality like him. In fact, he is one of the most quoted authors in almost all pivotal studies of non-alcoholic fatty liver disease. At a time when nobody even knew about the entity, Dr. Arun Sanyal did think of it and projected it that is going to be the future liver problem, which is turning out to be true. We are really, I think, happy, and we express our gratitude to have on panel a senior person like Arun Sanyal. I think with that, we can go ahead with the seminar.
It's Professor Woon Sui, who is the head of Department of Hepatology, University of Medicine 2, and she is also a vice president of the Myanmar Liver Foundation. Also, she is a patron of the Myanmar, an EC member of the Myanmar GI&Liver Foundation. She is very active academically, and she is now currently involved in many liver works as well as COVID-19 work. We will be talking about emerging trend in epidemiology of NAFLD and long-term outcome. Professor Winsway, please.
Thank you, Priyaji. Good evening, my professors, senior and junior colleagues. Today, I will talk about the emerging trend in epidemiology of NAFLD and long-term outcome. Introduction. Non-alcoholic fatty liver disease has emerged as a most prevalent liver disease worldwide, mainly because of the massive global increase in obesity. Extended public health and political efforts will be needed in the near future to counteract this disturbing development. Traditionally, obesity and its related disease have been considered a problem in Western countries. In the past 2 decades, urbanization in many Asian countries has led to a sedentary lifestyle and overnutrition, setting the stage for the epidemic of obesity. The term NASH was coined in 1989. After another decade, it was recognized that NASH is a part of the clinical pathologic spectrum of nephropathy. Uh, in the definition of the nephropathy, accumulation of the fat within the liver, hepatic steatosis, with no other known cause of hepatic fat accumulation. There is no evidence of excessive alcohol use. This means men 3 drinks per day, women 2 drinks per day. And it is defined by the imaging or biopsy of the liver. The fatty oil can be found in non-obese individuals also. And this nephropathy has a lack of the secondary cause of the hepatic fat accumulation. This means significant alcohol consumption, long-term use of the steroidogenic medication, or monogenic hereditary disorders. But this is commonly associated with the metabolic comorbidities such as obesity, diabetes mellitus, and dyslipidemia. Nephropathy is histologically into non-alcoholic fatty liver, NAFL, or non-alcoholic steatohepatitis NASH. NAFL means the presence of 5% of the hepatic steatosis without evidence of hepatocellular injury in the form of hepatocyte ballooning. NASH means presence of 5% of hepatic steatosis and inflammation with hepatocyte injury, example, running with or without other any fibrosis. For defining advanced fibrosis, referring especially to stage 3 and 4, that is basically fibrosis or cirrhosis. Nephropathy uh, in Asia and Western country. Prevalence of the nephropathy in the Western country and Asian country the same, 25%. A proportion of the nephropathy patients with the NASH difference in the Western country 20 to 30%, in the Asian countries 10 to 20%. According to the proportion of nephropathy patients with F3-4 steatosis in the Western country 10%, in the Asian country 3 to 5%. Prevalence of nephropathy in subjects with a BMI less than 20%, in the Western country 10%, Asian country 7 to 19%. Currently, the population prevalence of nephropathy in Asia is around 25%, like many Western countries. While hepatocellular carcinoma and end-stage liver disease can lead to the nephropathy remain common, a rising trend has emerged. Around the 8 to 90% of Asians with body mass index less than 25 kg per meter square are also found to have nephropathy. This condition often described as laying on non-obese nephropathy. Although this condition is generally less severe than that in more obese patients, steatohepatitis and fibrotic disease are well recognized. Global prevalence of the overweight and obesity is 39%, and global prevalence of the NAFL is 25%, shown by 2019 hepatology. Central obesity, insulin resistance, and weight gain are major risk factors, and genetic predisposition, such as the PNPL3 polymorphism, appears to be more important in the development of nephropathy in the non-obese population. Lifestyle modification remains the cornerstone of management for obesity and nephropathy, but few patients can achieve adequate weight reduction, and even fewer can maintain the weight in the long run. Recent advances in chronic hepatitis B and C therapies, combined with increasing prevalence of obesity epidemic, and other metabolic disorders such as type 2 diabetes mellitus and hyperlipidemia has led to the dramatic rise in nerve fatigue. So today, nerve fatigue is a major global health problem and has emerged as the second most common indication for liver transplantation in the USA and is projected to become number one soon. Recent events in chronic hepatitis B and C, and also the increased prevalence of the obesity and metabolic syndrome, and sedentary lifetime, poor dietary habit, overnutrition, and advanced age can cause a dramatic increase in the nerve fatigue. If the patient with the nerve fatigue, this may cause the NASH, cirrhosis, liver failure, and hepatocellular carcinoma, which lead to the need for the liver transplantation. As noted previously, due to the growing obesity epidemic now affecting more than 1.9 billion adults globally. According to the recent estimate, nerve fatigue affects as many as 1 billion individuals throughout the world. Similarly, in the USA, nerve fatigue affects nearly 80 to 100 million individuals, making it the number one etiology in chronic liver disease. Nearly 25% of patients with nerve failure progress to NASH. However, the true prevalence of the biopsy-proven NASH is difficult to determine, as the majority of the nerve failure patients do not undergo a biopsy. Although the prevalence of nerve failure is increasing throughout the world, there appear to be significant geographical variation. The global prevalence nerve failure is currently estimated to be 20%, and global distribution in the Middle East area 32%, South American 31%, Asia 27%, USA 24%, Europe 23%, and Africa 14%. Due to the increased prevalence of nerve failure, the prevalence of NASH is expected to increase as well. The proportion of nerve failure cases that progress to NASH will increase from the 20% to 27% by the 2030. Similarly, incidence of the decompensated cirrhosis is predicted to increase by 168% from 39,230 cases annually in 2015 to 105,430 cases in 2030. The prevalence of nephropathy continues to increase, and it is expected that NASH-related end-stage liver disease will become the leading increasing to liver transplantation over the next several decades. The corresponding value of NASH cirrhosis on liver transplantation is expected to increase by 59%. There are numerous studies. According to the numerous recent studies, NASH-related cirrhosis is the most rapidly growing indication for liver transplantation in the USA. In 2017, using the data from the UN work of UNOS database, reported as 162% increase in liver transplantation secondary to NASH from the 2003 to the 2014. While the liver transplant due to the alcoholic liver disease and hepatitis C infection only increased by 54% and 33% respectively. As the burden of NASH-related end-stage liver disease on the waitlist continues to rapidly grow, and the risk of the waitlist removal secondary to the death or progression of the comorbidities increase. There are so many long-term outcomes in the nephropathy. There are some are the good outcome and some are the bad outcome. Good outcome, NASH resolution can be achieved by the targeted weight loss by diet, physical exercise, pharmacological treatment, and surgical intervention. Nephropathy without significant fibrosis can regress completely. Many bad outcomes are liver-related causes and non-liver-related causes. Non-liver-related NASH is the risk of the liver failure, liver fibrosis, cirrhosis, and hepatocellular carcinoma. Hepatocellular carcinoma is risk advanced fibrosis, higher age, family history of ACC, lower serum albumin, higher gamma GD and accelerate treatment in diabetes mellitus and chronic viral hepatitis infection. Non-liver risk outcomes, cardiovascular risk and complication. They are very common by the complication as a complication of the nephropathy. Cardiovascular disease like the myocardial infarct, stroke, influenced by the both genetic and environmental diet. Obesity-related complications like obstructive sleep apnea syndrome, and also have the increased risk of developing diabetes mellitus and closely related to degree of glucose intolerance. Another outcome is the hyperuricemia, chronic kidney disease, and gallstone disease. And also very common disease is the polycystic ovarian syndrome, and also have the colorectal adenomatous polyp and colorectal cancer. And there are the so many summarized as my topic is number one is nephrology is very common in next few years, and there are the many complications and many outcomes. And it is currently a population prevalence on nephrology is 25%. And also today, nephrology is a major global health problem and has emerged as the second most common indication for liver transplantation in the USA, and is projected to become a number one soon. And there are many long-term outcomes. Nephrology has a good outcome and also many bad outcomes. And thank you very much and attention very for your kind attention.
For your very extensive review of the situation. And then I would like to move to the next speaker. Next speaker will be Professor Chosoton, who is currently the president of the Myanmar GI&LiverFoundation, who is extremely active in all the academic activities. And Professor Chosoton usually present with all the most up-to-date facts and with all the very lively cartoons. Professor Chosoton will be speaking on the cardiometabolic comorbidities of the nephrology, more than one disease. Professor Chosoton, please.
Good evening, Professor Arora. Good morning, Professor Arun Chanya, and all my colleagues. And thank you, Stefan, for sponsoring this masterclass in NASH. Today, I will be talking on cardiometabolic comorbidities of nephrology. Is it more than one disease? I have no conflict of interest for this presentation. So this is the spectrum of nephrology, and I hope Professor Wednesday has tell you about this. So the pathophysiology of nephrology is a complex and it is multifactorial. The disease, our diet, mainly the Western diet, with this high caloric, high fructose corn syrup, and genetics, in particular polymorphism of the pan-plus3 gene, obesity with adipose tissue expansion, enhanced lipolysis due to insulin resistance, resulting in lipotoxicity, mitochondrial dysfunction, production of reactive oxygen species, ER stress, autophagy, apoptosis, inflammation, activation of EVs, and ultimately HSD activation leading to fibrogenesis. And it probably acts in a different manner along with the different phase of the disease, leading to both liver-specific and extrahepatic manifestations. These are the spectrums and the percentage, and these are the histological pictures of different stages of NAFL. And these are the diagnostic criteria and the different biomarkers for different stages of the NAFL, which Professor Wonsui has just now mentioned it. I would like to touch a few on the dynamic natural history of NAFL. It is not a linear, or it is a steady progressive disease. You can see that a steatohepatitis between NASH and steatosis is began waxing and waning. Also, the fibrosis there is a rapid progression, or it can regress again. There will be a progression and regression throughout the fibrotic stages. And there are 20% of rapid progressors and majority are slow progressors. So this is this shows the dynamic natural history of NAFL. And then the risk of morbidity and mortality increases with the fibrosis stage. These are the secondary causes of hepatic steatosis, including leanness. Actually, NAFLD is a multi-system disease. As Professor Wednesday has said, the outcome of NAFLD ends up in with type 2 diabetes, the cardiovascular comorbidities, kidney comorbidities, obstructive sleep apnea, thyroid, most of all, the malignancies, including other outcomes like psoriasis and osteoporosis. Since 1997, the multiple subjects with multiple comorbidities with NAFL has increased, as shown by this picture. The impact of NAFL on the incident metabolic complications and mortality in reference to age and sex mesh controls are as shown. People with NAFL compared to without a NAFL in age mesh controls, they have a 2.6 times higher risk of getting one metabolic comorbidity. And then it is more than 1.6 for two metabolic and 1.62 from 2 to 3 metabolic comorbidities. And the death rate is high in NAFL than the age mesh control of normal population. The impact of NAFL on mortality decreases as the number of this metabolic condition increases. So this is the schematic putative mechanisms for the development of extrahepatic disease in patients with NAFL. As I have already mentioned in the pathogenesis, the adipose tissue and the liver crosstalk with this inflammatory cytokines leading to IR, and this insulin resistance leading to fat deposition in the liver, causing type 2 diabetes through hyperglycemia, hyperuricemia, and the pro-inflammatory mediators and oxidative stresses, which will lead to atherogenic cardiovascular diseases also. Later on, it will lead to extrahepatic malignancies like colorectal cancer through this pro-inflammatory mediators and then angiogenesis. There is increased cell growth and proliferative secondary to reduced adiponectin, increased leptin, insulin resistance, IGF, increased IGF, and increased VEGF. The complex play of NAFL and cardiovascular disease. And in this complex interplay, the liver is centrally positioned in the metabolic syndrome when NAFL can be considered as a consequence of mechanism driven by the other components of the metabolic syndrome. However, reciprocal crosstalk exists wherein the liver may actually drive diabetes mellitus or cardiovascular disease. These synergistic effects become more complex and create a vicious cycle. These are the summary of potential pathophysiologic mechanisms responsible for increased cardiovascular disease in NAFL. So both the endocardium, the myocardium are involved due to in this NAFLD, where the genetic and the adipogenesis and the dysbiosis has played a role. And these are the potential pathophysiologic mechanisms responsible for increased cardiovascular disease in NAFL. They are diastolic dysfunction, LV remodeling, altered electrical conduction leading to atrial fibrillation and cardiac arrhythmias, and the aortic valve calcification, and there are vascular wall abnormalities, endothelial dysfunction, the readout status leading to increased homocysteine and unaltered homocysteine. They are increased oxidative low-density lipoprotein. They are disturbed lipid profile. The angiogenesis is increased. The hemostasis is disturbed with procoagulative activities. The inflammatory cytokines like interleukin-6, TNF-alpha are also increased. And also the hepatokines, parasite cell signaling are also increased. Other mechanisms causing cardiovascular disease are sarcopenia and hypovitaminosis D. And the genetics, as I've said, FAMPLA3 and TM6SF2 mutation leads to NAFL. If you look at the stroke patients, the biochemical markers in NAFL patients has increased ALT, AST compared to controls. If we look at the diabetes and family history of diabetes on histological traits and interaction between personnel and family history of diabetes, we can see that in NASH and in NASH fibrosis, the personal history of diabetes has increased in NASH and fibrotic people. And second is the family history compared to normal persons. The other comorbidity, the big comorbidity is chronic kidney disease. From NAFL, the common visual obesity, arterial hypertension, atherogenic dyslipidemia, type 2 diabetes, metabolic syndrome, hepatic systemic insulin resistance, leading to low-grade inflammatory state, prothrombotic state, increased uric acid levels, leading to they are sharing the common platform for CKD. And if you can look at the NASH and controls, in NASH persons, they are abnormal albuminuria and increased incidence of CKD. And the EGFR is reduced exponentially with the severity of fibrosis. The potential mechanism and factors linking this NAFLD and CKD is the unhealthy, high-caloric, dense, fiber-poor diet leading to gut dysbiosis, leaking of this lipopolysaccharides, ethanol, short-chain fatty acids like butyrate, propionate, acetate, which the liver has to metabolize. And these liver metabolites can disturb or lead to renal dysfunction and leading to chronic kidney diseases. Other extrahepatic manifestations of NAFL are metabolic syndrome, where NAFL, NASH, and severe fibrosis, and people with metabolic syndrome are associated with a higher overall mortality in NAFL. Visceral adiposity causes a higher risk for NAFL than a subcutaneous adiposity. Type 2 diabetes, of course, increases the severity of NAFL, and NAFL can also increase the type 2 diabetes. As I've already stated, the cardiovascular comorbidities are common with NAFL, the chronic kidney diseases, and also hypothyroidism, psoriasis, and PCOS, polycystic ovarian syndrome, are common in NAFLD patients. Not only that, the urolithiasis, osteoporosis, periodontitis, and male sexual dysfunction are common in people with non-alcoholic fatty liver diseases. Not only the metabolic dysfunctions, they are also extrahepatic cancers from NAFL through the insulin resistance and dysfunctional adipose tissue, inflammatory cytokines and hepatokines, and the dysbiosis leading to extrahepatic malignancies like prostate, lung, breast cancers, cancers, renal, and even lung cancers are common in NAFLD patients. So, is NAFL a single disease? But liver involvement, you can see that liver involvement of NAFL has various stages. And then NAFL, or maybe sharing the common platform, has so many comorbidities like diabetes, cardiovascular risk, and kidney and malignant risk. And these are the mechanisms through excessive caloric intake leading to NAFL, obesity, and the risk of CVD. But if we go down to the genetics, the genetic markers for NAFLD is quite different from cardiovascular disease genetic background, if we rule out the obesity and diabetes. So these are the epigenetic mechanisms, microRNAs involving in the pathogenesis of this NAFLD. I can go into detail about this. So as we see, the NAFL is a very important disease, and still with a very big economic burden and with the current lack of FDA-approved therapies, NAFLD involves a highly complex interplay that calls for multi-tissue, multi-omic approaches. These are the multi-omic approaches, finding novel markers, genes, and biological pathways involved in different phases of NAFL. and molecular connections between NAFL and its comorbidities. And these mechanisms underpinning sex differences and probably for druggable targets. So if I have to conclude my presentation, the NAFLD implies that it is a non-alcoholic fatty liver disease, comparing alcoholic the commonality between alcohol consumption causing this ballooning degeneration and steatosis from non-alcoholic users. As we call it at NAFL, we have neglected the most important part of the metabolic comorbidities of this NAFL, which causes the greatest mortality in this NAFLD patient. So this is the one proposed by Professor Arun Sanyal. The metabolic dysfunction predominant fatty liver and alcohol predominant fatty liver. In there, it can be divided into metabolically predominant fatty liver without any alcohol, and then metabolically predominant fatty liver with some amount of alcohol consumption. And also in the alcoholic fatty liver, there will be no metabolic dysfunction and people with metabolic dysfunction. I think with this, we clinicians will be more aware of the metabolic consequences of this NAFLD, and the management approach and management planning will be more appropriate and more beneficial for our patients with NAFLD. With that, I would like to conclude my presentation, and thank you, CFAM and NDCIS, for organizing. Thank you very much. Thank you for your kind attention.
Just always, your slides are very interesting and most updated. Thank you very much. And we'll move on to the next speaker, Professor Win9. Could you come up with the video and the mic on? Professor Win9 is the head of Department of Hepatology of the University of Medicine 1 and the Yangon Specialist Hospital. And he is also a senior patron of the Myanmar Liver Foundation, as well as Myanmar GI&Liver Foundation. Professor Win9, please.
Thank you, sir, for your kind introduction. So good evening to everybody. Good morning, everybody. My topic is non-invasive assessment of the fatty liver disease, non-alcoholic fatty liver disease. Nowadays, there is an increasing prevalence of the NAFLD, and the severe outcomes of NASH may call for effective methods to identify the NAFLD. We usually do the liver biopsy. The liver biopsy is a good gold standard, but it is limited by its sampling bias, poor accessibility, and severe complications such as mortality, bleeding, and pain. So we need a non-invasive methods to avoid biopsy for diagnosing NAFLD. So NAFLD presentation is mostly it is asymptomatic, majority discovered by chance, and fatigue is the frequently present symptoms. And often NAFLD is the incidental findings, incidental abnormal LFT, incidental bright liver on imaging, incidental hepatomegaly, like checkup and then monitoring of the statin, annual reviews, and type 2 diabetes mellitus, hyperlipidemia, hypertension clinic, and we They then make medical insurance checkup and occupational health checks that can diagnose the NAFLD incidentally. So there is a programmatic step risk identification like a metabolic syndrome or other high prevalence group. The history should be alcohol intake less than 14 in the female and 21 in the male units per week. No known pre-existing liver disease, and we did an investigation like liver biochemistry, ALT, AST, etc. We have to exclude or identify other liver diseases, negative HBV, HCV serology, negative autoantibodies, negative celiac serology, and normal immunoglobulins and other ferritin, alpha-1 antitrypsin deficiency, copper, etc. And then liver ultrasound should reveal increased echogenicity and steatosis. So ALT can be normal in more than 50% of the individuals with NASH and 80% of the individual with NAFLD. So liver enzyme is assessing not good for the assessing NAFLD or NASH. So ALT can be elevated in more than 50% of the individual with NAFLD, but without NASH. So in NAFLD, ALT is neither indicative nor predictive of NASH or fibrosis stage. So normal ALT does not preclude NASH or progressive disease, and elevated ALT cannot predict the NASH or fibrosis. So ALT and AST is not sensitive markers for the NAFLD and NASH. So non-invasive tests, proper use of the non-invasive tests can aid risk stratification like demographics, vibration control, transient elastography, or the laboratory markers that enrich for the development of the NASH and the fibrosis. So the current non-invasive method is useful for assessing NAFLD, including steatosis, NASH, and NAFLD-related fibrosis. And we have to explore the advantages and disadvantages of the measurement of the tools. So in clinical practice, the potential non-invasive biomarkers are used for the tracking of the disease processes, monitoring treatment effects, and explore effective algorithms consisting of imaging and non-imaging biomarkers for advanced fibrosis. So diagnosis of the NAFLD can be done by serum biomarkers and biomarkers panel, fatty liver index, hepatic steatosis index, HSI, steatosis test, NAFLD screening score, or imaging by doing ultrasound, CT scan, control attenuation parameter, or magnetic resonance imaging. So fatty liver index is a prevalent biomarker panel consisting of body mass index BMI, waist circumferences, triglyceride, and gamma glutamine transferase. So for identifying NAFLD with a total score varying between 0 and 100, AURC of FLI for identifying NAFLD is 0.84, as the low cutoff 30 is used to rule out NAFLD, and the high cutoff 60 is ruled to use for positive likelihood of 4.3. So fatty liver index is poorly distinguishes between moderate or severe steatosis from mild steatosis. So HSI, hepatic steatosis index. HSI is a biomarker panel consisting of BMI, diabetes, and the ALT-AST ratio. So AURC of 0.79 and 0.82 and the derivation and validation groups, the two cutoffs 30 and 60 achieve more than 90% sensitivity and specificity. So it is a good specificity and sensitivity. So HSI accuracy decreases in obese children with the AURC of 0.67, sensitivity of 67%, and specificity of 62%. So it is not good for the obese children, but HSI poorly distinguishes moderate to severe steatosis from mild steatosis. Another one is steatosis test. Steatosis test is a biomarker panel consisting of 10 biochemical tests, age, gender, and BMI. So AURC of 0.8 for identifying more than 5% of the fat content in patients with chronic liver disease. So another one is NAFLD screening score. The NAFLD screening score is modeled with age, fasting blood glucose, BMI, triglyceride, ALT, AST, and uric acids. So NAFLD risk score includes 6 lab parameters with an AURC of 0.87 to 0.88. So imaging techniques, we have an ultrasound. This is a first-line imaging test used in a clinical practice. A typical appearance is hyperechogenic liver and sensitivity of 85% and specificity of 94% for moderate to severe steatosis. So ultrasound can inapplicable for detecting steatosis of less than 20% of steatosis in individuals with morbid obesity. The accuracy of ultrasound for hepatic steatosis assessment is affected by presence of severe fibrosis and intra and inter-observer variability. So to detect NAFLD in early stage, the computer-assisted ultrasound or hepatic renal ratio (HRN) US hepatic attenuation area attenuation rate are used to assess the steatosis quantitatively. Another one is the CT scan. So non-NASH CT scan has been used to evaluate severity of the fatty liver disease since 1970, and hepatic attenuation is inversely associated with the hepatic fat content. So normal liver has an attenuation value of 50 to 65 Hounsfield unit and 8 to 10 Hounsfield unit higher than that of the spleen. On error, the attenuation may be decreased to less than 40 Hounsfield units when fat infiltration occurs. Non-NASH CT outperform the ultrasound in evaluating the severity of the fatty liver. And contrast NASH CT imaging are another CT model and more suitable for severe hepatic steatosis using paraspinal or intercostal muscle because its sensitivity for mild to moderate hepatic steatosis is only 25%. So CT may also be used for the hepatic fat quantification, such as dual energy CT and hepatic attenuation measurement. Although CT is most effective, it is limited by insufficient accuracy for mild to moderate hepatic steatosis, and we have a radiation exposure, especially in the children. Another way is the CAP, Control Attenuation Parameter. CAP is a parameter based on the ultrasonic signals. It's used by the FibroScan with the M-Prod with a result of 100 to 400 decibel per minute. The CAP with an M-Probe is reported to have an AURC of 0.82 and differentiating any degree of steatosis versus no steatosis. So the cutoff of 240 decibel per minute yields a sensitivity of 69% and specificity for 82%. Another one is MRI. MRI determines steatosis by signal intensity differences on opposite face of the fat situation in MRI. So MRI drive proton density fat filtration. We call it MRI PDFF is a robust non-invasive MRI-based method for assessing the hepatic steatosis. So MRI visible protons that combine with the fat in the liver to quantify steatosis by dividing all protons in the liver. So MRI PDFF was significantly associated with the histological steatosis grade according to the NASH CRN grade, independent of age, sex, and other NASH parameters and NASH diagnosis. So MRI PDFF is superior to other imaging tools for the assessment of the hepatic steatosis, and its performance is not affected by the obesity. So MRI PDFF is also regarded as a robust, non-invasive method to monitor the treatment effect. Another one is HMRS. It is MR-based technique that directly measures the chemical composition of the liver, and it is used for the measurement of intrahepatocellular lipid through the calculating PDFF. A high correlation with the biopsy and steatosis assessment and sensitivity of 80% for the diagnosis of liver fat content in more than 5% of the cases. So diagnosis of the NASH is characterized by steatosis, ballooning, inflammation, with or without fibrosis, and which accelerate disease progression. So early detection of the NASH is conductive for prevention of the NASH-related fibrosis. So we use the non-invasive biomarkers like simple serum biomarkers, biomarker panels, and imaging. The first one is the cytokeratin 18, CK18. CK18 is an intermediate filament protein. It is cleaved during the period of cell death containing CK18M30 and CK18M65. So a meta-analysis of the 25 studies reported that M30 and M65 with the AURC of 0.82, the sensitivity and specificity was 75% and 77%. So combined metabolic syndrome, ALT, and CK18 in a morbidity obese population could achieve a AURC of 0.88 compared with the CK18 alone with an AURC of 0.87. The triple combination of the adiponectin, CK18, and interleukin-6 achieved an AURC of 0.90, a specificity of 85.7% and sensitivity of 84.5%. So the difference in the accuracy of CK18 in assessing NASH with the different stages of the fibrosis. Another one is inflammatory markers like the CACL10. It is a pro-inflammatory cytokines involved in the diabetes and obesity. CACL10 is exhibited a moderate accuracy of differentiating NASH from simple steatosis. Tumor necrosis factor alpha and interleukin-8 are common inflammatory markers, which also exhibit moderate performance with sensitivity and specificity of 72% and 76%. So when combining these two markers with a pyroglutamate, the panel could achieve a sensitivity of 91% and specificity of 87%. Adipocytokines and hormones. So fibroblast growth factor 21, FGF21, secreted by the liver and is another potential biomarkers for the NASH. FGF21 had an AURC of 0.62 and had a more than 90% sensitivity and specificity for the diagnosis of NASH with a positive and negative predictive value 0.59 and 0.87, 0.449 to 0.60 respectively. So FGF21 is combined with the CK18 to improve the positive predictive value to 82% and negative predictive value to 74%. Other serum biomarkers like the serum iron is a common protein associated with the oxygen radicals, which contribute to the necroinflammation and fibrosis. So serum iron was higher in individuals with NASH than in those with the simple steatosis. So in Japanese studies, serum ferritin exhibited a moderate performance for the diagnosing of the NASH. Another biomarker panel is NASH test. The NASH test combines 30 parameters to diagnose NASH in 3 categories: NASH, borderline NASH, and no NASH according to the cleanest criteria. A study of 257 people found that the NASH test achieved an AURC of 0.79 for NASH and 0.69 for the borderline NASH and 0.77 to 0.83 to no NASH. Another one is NASH Clean Lip Med Score. The NASH Clean Score is a biomarker panel combining AST, fasting insulin, the PNPLE3 genotype at a RS73X409, which achieve an AURC of 0.78 for diagnosing NASH. So to improve the accuracy, the metabolic syndrome-based factors for the NASH, which was named NASH Lip Med Score, that improved the AURC to 0.87 and the sensitivity to 75%. Other biomarker panels like biomarker panels parameters of BMI, ALT, and triglyceride. So AURC of 0.80 to 0.82 in training validation cohorts only include 180 morbidity obese patients after bariatric surgery, and clinical score of ALT, GGT, and C-reactive protein, ApoB and ApoA1 ratios. So the cutoff of 3.8 gave a sensitivity of 90% and specificity of 87% for distinguishing NASH from the NAFLD. So imaging for the NASH. So NASH consists of various parameters, ultrasound, CT, and MRI to distinguish between NASH and simple steatosis. Elastography was investigated to distinguish NASH and simple steatosis. So the cutoff was 2.74 kPa for MRI. MRE had an AURC of 0.93, but the study had several limitations. Another way is VCTE, vibration controlled transient elastography, which was performed in South Korean patients with an AURC of 0.75 and sensitivity of 86% for the diagnosing of the NASH, but specificity was only 58%. The liver iron accumulation LIC measured by the MR signal decay value is significantly related to nephrotic disease severity and fibrosis progression. So MR-based technology assessing LIC was found to have an accuracy of 0.91 for assessing NASH with a sensitivity of 83% and specificity of 80%. The new biomarkers like circulating microRNAs are potentially regarded as attractive biomarkers for the NAFLD, and meta-analysis found that microRNA 34A was reported to have a moderate accuracy of 0.8778. MicroRNA 122 had a poor accuracy of 0.64 to 0.70 for differentiating NASH and simple steatosis. So the combination of the microRNA 122, 192, and 21 with CK80 and ASP396 achieved an accuracy of 0.83 for diagnosing NASH, while the optimal cutoff gave a moderate sensitivity and specificity. So other biomarkers are like bread volatile organic compounds, VOC, and bread VOCs are closely related to oxidative stress, inflammation, and liver diseases. So a panel consisting of 3 acyl compounds, 1 propanol, 3 methyl butanoate, and tridecane had an accuracy of 0.77, PBV of 81%, and NPV of 82% for differentiating NASH and non-NASH. So non-invasive biomarkers of NASH are an attractive field. CK18 is regarded as a popular biomarker for NASH, but the accuracy varies in current studies. So biomarker panels perform well in diagnosing NASH, but most of them are not validated. Although the other non-biomarkers, such as imaging and gene biomarkers, they are reported relatively high accuracy. Effective methods should be available, simple, inexpensive, and accurate in clinic. The serum biomarker CK18 are less accurate for diagnosing NASH with the mild fibrosis, which could lead to higher rates of misdiagnosis. So to improve the diagnosis in early NASH, biomarker panels or combination of the serum biomarkers with the imaging may contribute to ruling in or ruling out of the NASH with the early fibrosis. Another one is diagnosis of the nephropathy-related fibrosis. So we can use non-fibrosis, mild fibrosis F0 to F1, significant fibrosis F2, and advanced fibrosis F3, and cirrhosis like F4 and Medavir score. So it is urgent to identify early fibrosis through effective non-invasive method. So proprietary biomarkers like a collagen, procollagen type 3, P3NP, precursor of C3 protein, hyaluronic acids, and TIM1s, they are the markers of the proprietary biomarkers. And another one is NS liver fibrosis ELF test. ELF test is a commercial tool that combines 3 circulating matrix turnover compounds, including hyaluronic acid, P3NP, and TIM1 with age. So using a cutoff of 9.8, and the ELF test identify advanced fibrosis with positive predictive value of 72% and negative predictive value of 97%. Non-proprietary biomarkers are AST to platelet ratio index, fibrosis 4 index, nephrotic fibrosis score, and BART score. So every is the simpler calculation for diagnosing fibrosis, severity, and chronic hepatitis C. And recent meta-analysis reported that every had an accuracy of 0.70 for significant fibrosis and 0.75 for advanced fibrosis, and 0.75 for the cirrhosis. So poor sensitivity of the EBRI was relatively low with a range of 0.33 to 0.73 for different cutoff. FIB4 is a common biomarker panels used for the assessing fibrosis and severity, including age, platelet count, AST, ALT. FIB4 was primarily devised to assess the liver fibrosis severity in hepatitis C patients. An accuracy of value of 0.75 to significant fibrosis and 0.80 for advanced fibrosis and 0.85 for cirrhosis was reported in NAFLD patients. On the other hand, using cutoff of 3.25, FIB4 predicted advanced fibrosis with 26% sensitivity and 98% specificity, 75% PPV and 85% NPV. So FIB4, the two cutoffs may improve PPV and NPV, so avoiding unnecessary biopsy. So the specificity of the FIB4 was 0.35 for assessing advanced fibrosis in elderly individuals more than 65 years of age. So FIB4 is not good for the elderly patients. So NAFLD fibrosis score, NFS is the most common non-invasive biomarker panel for assessing fibrosis severity. It consists of age, BMI, hyperglycemia, AST-ALT ratio, platelets, and albumin. A multi-center study reported low cutoff of 1.455 for advanced fibrosis with a positive predictive value of 51% to 56% and negative predictive value of 88% to 93%. Using this model, 75% of the biopsy could be spared with a 90% correct prediction. So NAFLD fibrosis score was widely validated in different regions. The NFS and FIB4 are recommended to identify those at a low and high risk of advanced fibrosis or cirrhosis and clinical guidelines. Another one is a BART score. The BART score was an essential, easily calculated score using parameter of BMI, aldosterone activity ratio, and the presence of type 2 diabetes mellitus. A score of 2 to 4 increased the risk of the advanced fibrosis by 74, where the AORC was 0.81% to NAP of 96%, low predictive value of 43%. Imaging like the VCTE. VCTE is the first FDA-approved elastographic modality performed by the FibroScan Embroid US-based technology. And this technology measures the velocity of 50 megahertz shear wave that is emitted by a probe in the intercostal space. And the technical failure was found to be more common phenomena, ranging from 6.7% to 27%, and was related to the high BMI. So Embroid was the most prevalent probe used for the high BMI patient. Second one is a shear wave elastography. Shear wave elastography is a new method integrated into conventional ultrasound for assessing the fibrosis. Can measure the shear wave velocity and provide 2D real-time color map or level elasticity. Should be conducted under apnea. Shear wave elastography reportedly has a high diagnostic performance for fibrosis assessment in chronic hepatitis B patient. And shear wave is better than the FibroScan and acoustic radiation force impulse RFI. And no specific regulations are recommended by the manufacturer for assessing the quality of the measurement. And some studies assess the failure rate of SWE with the reliability criteria for FibroScan. RFI is elastography, alternative tools for fibrosis assessment integrated into conventional ultrasound. It uses short-term acoustic pulses to produce shear wave with the results expressed in meter per seconds. RFI should be operated under apnea, and the region of the interest should be vessel-free region. The AORC of 0.77 for significant fibrosis and 0.84 for advanced fibrosis and 0.84 for the cirrhosis. MRE. MRE is the non-invasive MRI-based method using a liver stiffness by using modified phase contrast method. MRI can assess the entire liver with a high success rate in. It is not affected by steatosis and may be applied in patients with obesity, ascites, bowel interposition between the liver and the abdominal wall. So MRE is available model contains 2D MRE, 3D MRE. 2D MRE is more frequently used for assessing fibrosis and NAFLD patients. 3D MRE had a better performance for detecting of the advanced fibrosis than the 2D MRE. MRE was superior to FibroScan and RFI and common biomarker panels for discriminating dichrotomized fibrosis stage in NAFLD patients. So considering higher accuracy of MRE in diagnosing fibrosis, it is increasingly regarded as a promising surrogate biomarkers for monitoring fibrosis progression and endpoints of fibrosis therapy. Other new biomarkers like the serum DNA methylation and plasma DNA methylation or PPERR promoter was reported to have a good performance for diagnosis of the advanced fibrosis with a cutoff of 0.81 to positive predictive value 91% and negative predictive value for 87%. So biomarker panels are cheap, feasible, reproducible, and good negative predictive for fibrosis, but they are limited by its low positive predictive value. So MRE shows excellent accuracy for fibrosis severity and only be used in some drug studies. Transient elastography, together with the biomarker panels, was widely used for assessing fibrosis, but the efficacy should be evaluated in more independent groups. So it is recommended to combine serum biomarkers or clinical rules with the imaging tools to diagnose fibrosis, which could reduce the unnecessary diagnostic biopsy. So non-invasive biomarkers are used for the progression and therapy and tracking of the disease progression and hopefully significantly increase the risk of the liver disease, morbidity, and mortality. So fibrosis, not a simple steatosis and NASH, increase the risk of the mortality and NAFLD. One stage of fibrosis progression takes 14.3 years and 7.1 years in individuals with a simple steatosis and NASH patient. So most of the NAFLD cases are asymptomatic until the disease is progressed to cirrhosis. So there is a needed to apply useful non-invasive biomarkers to monitor disease progression. Tracking disease progression, we can use liver histology, APRI, FIT4N, and NFS for the predicting clinical outcomes, ARO-RC of 0.85, 0.89, 0.89, 0.79 respectively. And FibroScan had an accuracy of 0.73 for predicting all-cause mortality. Further studies are needed to determine more effective non-invasive biomarkers for the progression of the NASH to NASH-related fibrosis and progression of the NASH-related fibrosis to advanced clinical outcomes. Regarding the monitoring of the response to therapies, NAFLD treatment, it is impractical to observe the primary endpoint for mortality due to long-term follow-up. So FDA recommends that histological improvement be confirmed when the resolution of the NASH is obtained. However, repeated biopsies hinders the development of the drugs. So MRI-PDFF was usually employed evaluates liver fat content, and study of nearly 113 NASH patients treated with the obeticholic acid found that MRI-PDFF had an AURC of 0.81. In contrast, phase 2 trial of the cilontinib found that MRI-PDFF had an AURC of 0.70 for the reduced histological steatosis grade. So whether the change of MRI-PDFF could be regarded as an effective surrogate endpoint for NASH treatment should be further evaluated. So MRI-PDFF was used to employ to evaluate the liver fat content change in clinical trial for NASH patients. So monitoring of the response to treatment. So liver function test was regarded non-invasive biomarkers for assessing the monitoring of the treatment effect. While AAT concentration is about 2/3 of patients is normal, the NASH patients usually is a bit spontaneous change in liver function. So ALT changes is usually accompanied by steatosis changes. The change in liver stiffness measurement measured by the MRE was evaluated to investigate anti-fibrosis effect in NASH. So MRE had an AURC of 0.62 and PBV of 39%, and PBV of 92% for fibrosis improvement. So in conclusion, extensive development of the non-invasive methods in NAFLD patients from serum biomarkers and imaging omics. Ultrasound and HMI have a relatively high accuracy for diagnosis of NAFLD, and the US is prevalently used in the clinical practice and research due to the availability and low cost. So there are currently no effective invasive biomarkers recommended for diagnosis of the NASH. Future studies are needed to investigate more efficient non-invasive biomarkers for distinguishing NASH from simple steatosis. PCT and FDA-approved elastographic model for assessing fibrosis severity. The effective algorithm consisting of imaging and non-imaging biomarkers should be applied to clinical practice. In addition, there is a need to investigate the cost-effectiveness of non-invasive biomarkers in diagnosing NAFLD and tracking disease progression, monitoring response to their therapies. So thank you very much for kind intention. I'm going to hand back to Professor Kimawin.
Could I ask Anil to invite and introduce Professor Arun Sanya, please?
Hello, Amit, you're there? Professor Kim, can you hear me?
Yes, sir, we can hear you.
Thank you all the speakers for excellent presentation. Till now, what we had, an excellent talk from Dr. Win Sui. She clearly told us the rapid increasing burden of non-alcoholic fatty liver disease. In fact, this is something called visible coronavirus. I'm thankful to Professor Sanyal for having told us about this disease decades ago, even if when most of us were not even aware of it. So this is no less than coronavirus, which is an invisible enemy. In fact, it is a visible enemy which is apparently seen. Then we had a talk by Professor Sotun, who very elegantly tried to simplify the complex, intricate relationship between the metabolic syndrome, cardiovascular mortality, and the renal involvement. And finally, Dr. Niang told us how to assess the various components of the fat, NAFLD, NASH, and the assessment of the fibrosis in this complex disease, ultimately boiling down to something around 70 to 80% AUROs in almost all the disease. But the tenet of the medicine is anything you diagnose, unless you have an effective therapy, it is of no use. And we have none other than Professor Sanyal, who is going to take us forward to current developments in treatment of non-alcoholic steatohepatitis. Professor Sanyal, please.
Thank you. Good morning, or I guess evening, in Myanmar. Yes, evening. It is definitely evening. So here are my conflicts. Okay, I think we've already heard that non-alcoholic fatty liver disease often occurs in the setting of systemic obesity and metabolic syndrome. Amit, what are you doing? Can someone stop moving my slides around? Okay, thank you. So it is really important to think about what is happening with our patient. Our patients are at immediate risk, not only from their liver disease, but from a variety of other ailments that involve the heart, their arteries, the pancreas, and the kidneys. And the common element across all these comorbidities, which are commonly present in our patient, is the presence of metabolic stress that is related to systemic inflammation and fibrosis. And so there is common biology that connects all of these different end organ diseases that frequently occur at the same time. Now, the issue with competing risks is that treating one condition without paying attention to the others means they will simply be killed by another disease and not the disease you're treating. So if we really want to improve the long-term outcomes for our patient, we need to improve the outcomes for all of the competing threats to life. And to do that efficiently, we need to get to the root cause, which is the metabolic stress that these patients are under. And this is linked to diet-induced obesity. So weight loss is the most common therapy, as shown in this cartoon. that has been shown to benefit each and every one of these end organs. When we look at the liver disease, there's also literature that weight loss is beneficial. But there are some myths associated with weight loss that is worth talking about. First of all, we claim that weight loss will improve the NASH, and frequently you will hear people say that a patient has to be tried on simple weight loss measures for 6 to 12 months before drugs are provided. Well, let's test that hypothesis. If you look on the left over here, you will look at the number of people who did not resolve their steatohepatitis. And you can see over here that a large number of these patients had weight loss. In fact, you hear that you need 5% weight loss to get resolution of steatohepatitis. If you draw a line right here at 5, you will see that a large number of people lost more than 5% of their body weight, but did not resolve their steatohepatitis. Conversely, if you look at those who resolved their steatohepatitis, you will see that a lot of these patients actually over here, the majority of these patients did lose weight. So weight loss is beneficial, but does not guarantee that you will resolve your steatohepatitis. We also say that you need 10% weight loss to improve fibrosis. If you draw a line at 10% over here, and you look at the number of people whose fibrosis improved, I don't know what's that. Okay. Look at the number of people whose fibrosis improved. You will see that the majority of people whose fibrosis regresses over time actually did not lose more than 10% weight. So the issue is far more complex, and therefore we need pharmaceutical development to continue to help our patients who have this disease, because the improvement in liver histology is not a simple function of the degree of weight loss. Now, moving on, we also know that from bariatric surgery that the disease activity improves, but advanced fibrosis, particularly this is the population that is at risk of liver-related outcomes, frequently does not improve so much. So if you look at over here, whether you had steatohepatitis or you're not, you can see that after bariatric surgery, steatohepatitis resolves in a lot of people. But if you look at the people who had persistent severe fibrosis, about half the people, 46%, continued to have severe fibrosis. And so this again tells us that weight loss is not the only solution and cannot be used as an excuse to prevent drug therapy for our patients. Furthermore, if you lose a lot of weight, it leads to some unexpected consequences. So this is data from the US combining, now you can see many different studies. And what they uniformly show to different degrees is that the suicide risk is increased after bariatric surgery. And the reason for this is that many patients eat excessively to cope with stress and depression. And when you remove their coping mechanism without offering an alternate coping mechanism, then it aggravates the underlying depression. So there are other things that you have to think about when making recommendations about weight loss. So for all of these reasons, we need to continue to look for pharmacological means in addition to our lifestyle changes that we should recommend to all of our patients. Now, there are new drugs being developed for weight loss. And the one that is particularly interesting because it seems very non-toxic is the Gelesis 100. This has already been approved in the US for obesity and should be on the market later this year. And the basic concept is very simple. There are these simple granules, which when you take by mouth, when they go into the stomach, in contact with gastric acid, they swell up and essentially occupy the lumen of the stomach, so thereby triggering the satiety signals from the stomach so that you stop eating and you end up eating less. So you just take a capsule right before your meal and you'll end up eating less. And the data show that over here, as you can see, if you look at proportion of people losing more than 5%, 7%, or 10% weight, those who were on the Gelesis compound, almost a third of these patients lost more than 10% weight, and over 60%, about 60% of these patients lost more than 5% weight. And you can see over here, this is just shown as adjusted risk reduction on the right-hand side. So this is potentially a compound that could help with weight loss, but also in the process of improving weight, impact all of the end organs that our patients have affected. The second procedure that is very interesting is the concept of duodenal mucosal resection, so resurfacing. And this involves putting a needle through a scope into the plane between the mucosa and the submucosa, lifting that plane with hot saline and creating a thermal burn circumferentially for about 10 centimeters, and then allowing normal mucosa to reform. What that does is that it reduces the kind of cells that are in the proximal gut and reduces the hormonal response to food. And it has been shown in a phase 2 trial that 60% of patients who underwent this had defatting of the liver. And a pivotal trial is now being developed. These data are now shown over here, where you can see that approximately you have 5.4% absolute fat change and a relative change of 32% median. Going on to other drugs that are more liver related, there's a lot of activity which targets the 4 phases of pathogenesis, from metabolic overload, cell stress, inflammation, and fibrosis. So let's review these quickly to see where we stand. Here is a profile of some of the drugs that are leading the way, including FGF and the FXR axis, the FGF21 axis, thyroxine beta receptor, and the GLP-1s. And the goals, if the goal is to improve all of the end organs, it's important to look at what these drugs also do to the lipid profile. And you will notice that several of these actually increase LDL cholesterol, and that has to be taken into consideration. And we don't have the MACE data. So it is very important when we evaluate the liver benefits of many of these classes of compounds, that we also look at the effect of these compounds on the heart and on the kidneys. So with that background, let's look at the liver-related outcomes in these patients. Starting first with phase 3 trials, which are furthest along and for which we have the largest amount of data. The regenerate results are out, and so let's look at this real quickly. So before we go into phase 3, it is important to understand that as you get to bridging fibrosis, your mortality risk increases. Your background mortality risk before stage 3 is relatively low, and then the highest mortality is in cirrhosis. This is linked to liver-related outcomes, as shown on the left, whereas by fibrosis stage, actually coronary artery disease outcomes are constant. Part of it is because of the attention we pay to the heart and manage the cardiovascular disease very aggressively in this population. Cerebrovascular disease also rises with increasing fibrosis. Again, there is a collinearity between the risk of outcomes across multiple organs as you progress. So the natural course of the disease can be divided into, thinking like a metro station, into these stops. So one stop is what we call clinically significant fibrosis, which is NASH with fibrosis stage 2 or 3, which then can progress to cirrhosis and then to outcomes. Cardiovascular outcomes can occur throughout the course of this, while liver outcomes occurs over here. So the goal is to take people at this station and stop them from going to the next station or preventing progression to cirrhosis. So the regenerate trial looked at 10 and 25 milligrams of obeticholic acid and FXR agonist and looked at fibrosis improvement by 1 stage or more without worsening of NASH, or NASH resolution without worsening of fibrosis as their primary endpoint. And you can see over here, there's a small but statistically significant differential in terms of the proportion of people who had more than 1 stage fibrosis improvement. And on the other hand, if you look at percentage of people who had resolution of NASH, this did not reach significance in the primary ITT population, shown on the left. Now, when you include people with stage 1 disease also, not just stage 2 and 3, then these become significant. And this may be partly because of the greater plasticity of the disease earlier in the course of the disease. Now, when you look at the overall pathologist assessment, there are two ways you assess NASH resolution, either by demonstration of ballooning to be 0 and inflammation to be 0 or 1, or by an overall assessment by the pathologist. So when you look at the overall pathologist assessment, it was significantly improved as well. And mind you, this is blinded assessment. We also know that once you get past the 18-month time point at which these histology were obtained, non-invasive measures show that liver stiffness continues to improve over time. All of these together suggest that the drug indeed does improve the liver status, both in terms of injury and inflammation. There is currently a lot of debate on the benefit and risk analysis. We already talked about these benefits, but on the right-hand side, there are rare cases of hepatotoxicity. In Regenerate, there's also a small but significant signal for gallbladder-related complications like acute cholecystitis. And then it causes the LDL cholesterol to go up. And there's also pruritus. Now, the pruritus can be managed in most patients, and the dyslipidemia can also be controlled with statins. But these give you pause for concern. So we need more real outcomes data to see whether these biochemical changes actually translate into increased risk for outcomes. Also, it probably makes sense if you're going to use obeticholic acid to get an ultrasound first and be very cautious, if at all, to use it in people with gallstones. That's my personal view. And if you do not have gallstones, after starting OCA, probably should get an ultrasound after 2 months to make sure you have not developed de novo gallstones. The lipoprotein story is very important because when you use obeticholic acid, you actually increase LDL cholesterol because cholesterol can be converted into bile acids, and when you block it with obeticholic acid, that cholesterol has nowhere to go. So it ends up in VLDL and eventually into LDL. But when you reduce the amount of triglyceride coming out of the liver, the VLDL particles can be chewed up very easily. So you end up basically with larger VLDL particles, larger LDL particles, which are less atherogenic. It is also important to place LDL cholesterol rise in clinical perspective. The relationship between changes in LDL cholesterol and clinical outcomes is shown on the left. This is a very important graph in my view for anyone who is treating NASH. On the left, you are looking at as the differential between two groups increases, you can see the rise in event rate. On the other hand, if you decrease LDL cholesterol, the decrease in risk is shown on the right. And this is a linear relationship along a log scale. And so what that means is if you take LDL over here, the differential is about 0.4 millimoles, which is about 10 to 20 milligrams. So your risk of a cardiac event is about 6% of a background risk of about 1%. So about 0.06% differential over a 3-year time frame. So when you start thinking about risk, we really need to understand, instead of just jumping up and down about LDL cholesterol, we really need to know what we mean by how much of a risk the specific amount of LDL cholesterol actually imposes on our individual patient. Other agents in phase 3 include elafibranor, which the primary outcomes have been put out by the company, did not meet its primary endpoint, and these other trials are currently ongoing. Moving on to phase 2 very quickly, very exciting data from India with a drug called saroglitazar, which has been shown to reduce liver fats, which is shown in orange over here, and they're showing the proportion of people with more than 10%, 20%, and 30% fat, along with improvement in ELF. Phase 2 histology-based data should be coming later this year. There is also a study from Pfizer using a ACC inhibitor showing very remarkable defatting of the liver, almost 70%, but it is associated with hypertriglyceridemia. But that can be managed with a fibrate. There's a lot of interest in SGLT2s, and these are data with SGLT1 and 2, which also affects both intestine and the kidneys, and showing decrease in body weight, decrease in ALT, GGT, more data coming. GLP-based therapeutics are very exciting because they improve cardiac outcomes, all-cause mortality, chronic kidney disease, cause weight loss, and now semaglutide is coming on strong, and these are data showing weight loss with semaglutide. These are data with combined GLP, GIP, and GLP, and there's also data with GLP-1 and glucagon agonists. The top-line data from semaglutide were just put out there and produces 60% resolution of steatohepatitis, but did not have a big effect on fibrosis. And time will tell whether the time course of improvement in steatohepatitis will translate into improved fibrosis or not. Lastly, combination therapeutics are coming. It is definitely the future, but it requires knowledge of the population. One size does not fit all. We have to match the mechanism of action to drivers of disease at different points in the course of the disease. The root cause has to be the anchor. So you have to have a metabolic target as the anchor for combination therapy. For early stage disease, you can use 2 metabolic targets, but for advanced stage disease, including a metabolic and antifibrotic regimen makes sense. Very important, should not just blindly follow the pack, and should not try to treat everybody regardless of stage and what is causing their disease at a given stage to treat them with a single combination. So the paradigm for the future is going to be, when you make the initial assessment, we start with weight loss regimen, lifestyle, and with or without drugs, use of statins and fibrates versus saroglitazar for managing atherogenic risk, use of SGLT2 and GLP-1 agonists as indicated if you have type 2 diabetes and have significant risk for cardiovascular and renal outcomes. After a period of initial therapy with these common drugs, you reassess residual active disease, and if they still have fibrosis stage 2 or higher and have active disease, then we want to consider treatment to reduce progression to cirrhosis and liver outcomes, and ultimately then reassess periodically to document that the health of the patient has actually been improved. At the end, all drugs being developed will need to show that you're reducing mortality, reducing healthcare cost, improving the functionality of the patient, and the quality of life. So I will stop there and be happy to take questions.
Pharmaceutical therapy in patients with non-alcoholic fatty liver disease. With that, we come to the end of the formal session, and I think we'll start taking the questions from the audience. Professor Kim, you want to start? At the beginning, may I ask Professor Kanyal, so in the current regimen, what is the indication in a patient who comes to hepatologist for treatment of NASH? Which patient do you select for pharmacotherapy, and with which drug to begin with?
So the first, as I said, I look at the overall profile of the patient. If the patient has type 2 diabetes, particularly if they have type 2 diabetes and have significant cardiovascular risk, that, and they have relatively early disease, that is up to stage 2, their risk up to stage 2 is predominantly cardiovascular. So for those patients, I would focus and talk to their endocrinologist or primary care physician about initially managing them with a GLP and a SGLT2, either alone or in combination. Now, I would reassess that patient at some point in time to see if their liver stiffness is worsening towards stage 3. For those who already have stage 3 or have advanced fibrosis, you will need something more than just starting with simple treatment. So you start with your metabolic stuff, but then you have to think about what other drugs can you use. Now, depending on where you are, if you have access to obeticholic acid, or you have access to what drugs you have access to. If you don't have OCA and you do not, I have to point out that saroglitazar, the data for the liver disease is still very early. We don't have, it may very well be the magic drug, but we don't have that evidence yet. So in the absence of those, you are left with pioglitazone and with vitamin E, again, as your, the drugs that are commonly available. Now, GLP-1, so your list is GLP-1, pioglitazone, and vitamin E, followed by SGLT2 inhibitors in terms of the evidence to support liver treatment. So again, I would, if a patient is diabetic, I would start with the GLP-1 if they can afford it. If not, consider one of the alternate drugs. If they do start pioglitazone, it is very important that an aggressive attempt to do lifestyle intervention is also made to minimize. We have shown previously that using that approach, you can actually minimize the weight gain that is associated with pioglitazone. And I think probably the best evidence for improved histology and fibrosis is with pioglitazone followed by vitamin E.
Professor Kim?
Professor Arun Sanyal, there is a question asked by the audience regarding the colorectal cancer screening. Is there any specific guideline? Professor Wimsey has said above the age of 50, people should be screened, but how often, what is the guideline or something for us to follow?
There is no formal guideline means that a society has put its stamp on it. So there, to my knowledge, there is no guideline yet. But there is evidence that patients with NAFLD tend to get adenomas, high-risk adenomas earlier, and they even carcinomas earlier at a younger age. And so in general, there is already a trend that we are seeing colorectal carcinoma at an earlier age. In the US, the practice guidelines have now started shifting towards starting screening at 45 instead of 50 years of age. So certainly in our patients with NAFLD, what I do clinically is that at 45, I will start the screening process. If they have a family history of colorectal cancer, I will start it at age 40.
Age 40.
Now, it's not necessarily evidence-based, but because of the family history, I shift it up a little bit, but that's my best guess in the absence of huge amount of data.
Here is where the FXR agonist will also be pretty useful, because these are the drugs which are known for the change in the microbiota, gut microbiota. They are known to decrease the incidence of colonic adenoma. You think that will be a collateral advantage of OCA? FXR agonist, yes.
Which
OCA.
drug? OCA?
Yeah.
Potentially, but you have to generate the evidence to actually say that. Without data, in God we trust, everybody else needs data.
Professor Arun Sanyal, Dr. Aun has asked how soon the NAFL will be changed to MAFLD.
It will not. So I have to tell you, since you opened that question, let me give you a little historical background. When we wrote that paper with Jacob, the idea was to raise awareness and to discuss that non-alcoholic is not a good terminology and that we need to really have a conversation about this. And originally the idea was that at EASL we would have sort of a larger multi-stakeholder discussion about it. But somewhat to my dismay and surprise, a paper showed up in Journal of Hepatology which claimed there was an international global consensus on changing the name, which had not a single person from the US on it. Now I can tell you the reason we wanted caution was because 25 years ago, this disease was in the realm of academia. Okay, nobody cared about NASH. As Anil mentioned, we were studying NASH when nobody cared about NASH. So at that time, we would have these very vigorous debates. But now, over 20 years, we've had many conversations with policymakers, with WHO, with government health agencies, insurance companies, etc. They've gotten used to a certain type of nomenclature. We still have major challenges in educating our colleagues in the diabetes world and family practice. That is where most of our patients, that's where they live. And so by switching gears midstream raises the potential for worsening that confusion. Number two, we already have ICD-9 codes that have been developed, and there is a huge process for changing ICD-9 codes. And by changing name midstream could affect access to care and reimbursement for care for patients with this disease. Lastly, when we did a patient survey, many patients, at least in the US, say that having the word non-alcoholic allows them to talk about what they have with their family, with their friends, at their work, and they are not labeled as someone who is an alcoholic, because any other liver disease gets labeled as alcoholic. Last but not the least, the term metabolic, MAFLD, is a really poor choice of language because alcohol liver disease is also metabolic. That's how alcohol causes liver disease, by altering metabolism and the redox state in the liver. Wilson disease is a metabolic fatty liver disease. So replacing one bad terminology with another bad terminology also does not accomplish much. So yes, no question that non-alcoholic is a very poor term because it's a non-term. But when we change, at this point, given where the field sits, it has implications. Plus, where the field is going is subsegmenting the population in terms of risk. A very important question is, why do some people get a heart attack first? Some people get cirrhosis first. Some people get CKD first. How can we subsegment these populations? And maybe we should be more forward thinking in terms of, if we're going, when the time comes to change nomenclature, be more forward thinking and integrate the science and the data generation, which is coming now, with our regulators and policymakers and WHO and people, so that it is everybody is in synchronized step rather than in dyssynchrony. And so there is actually a paper that has been now accepted in hepatology to rebut the paper in Journal of Hepatology that should be coming out. It's accepted. It should be coming out in the next week or two. Going through this process, the idea is not to argue about whether non-alcoholic is a good term or a bad term. We all agree it's a bad term. But the question is, change for the sake of change, or to make an academic professor feel good about himself, is a poor reason to change something when it could have a negative impact on many other aspects of the disease. So that's the point. And I think you will see more vigorous debate about this as the year unfolds.
Okay, very clear. Thank you very much. The last question for you, Professor Arun Sanyal. What is the dose of Gelesis?
It's a Gelesis 100. So you get the, so they're 100 milligram capsules. So it's a pretty small capsule. And because it swells, you go to the restaurant where they give you a little, on a plate, it looks like a small tablet, and they put a drop of water on it and it swells up and becomes a big napkin. It is the same concept. It absorbs the water and acid in the stomach and swells up. So, and then over time slowly disintegrates. So it doesn't sit, you don't get a bezoar because it fragments over time into microbubbles. And within 3 to 4 hours, it's gone from your stomach.
How long can?
Thank you very much.
How long can you use it?
Sorry? Gelesis, you can use, you take it with every meal. You just take a pill before you start eating. You just reduce it down. Yeah, you can take it because it's non-toxic. It's not absorbed in your body. What you eat, you poop out. So it has no toxicity associated with it. So that's the beauty of it. Even if the weight loss is modest, the fact that it is non-toxic is really, bariatrics comes with a pretty significant cost to the patient in terms of changing their anatomy, their physiology, the issue with depression, the need to monitor for B12 deficiency, iron deficiency, osteoporosis, all kinds of other problems that come with it. This is a much simpler fix. It's just a pill, and if the cost is right, it could be very valuable.
Arun, another important question asked by somebody is that both in lean as well as obese NASH, the basic cardinal problem is insulin resistance, which could be at the level of formation of the insulin, its structure, its receptor and post-receptor activation of the metabolic processes. Is it anything being done to take care of that? Because that will take care of many other things. Any attempt?
So the insulin resistance is not at the level of its production. There is a burnout of beta cells late in the course, but the primary peripheral insulin resistance is due to what we call metabolic inflexibility. So when you are fasting, your insulin levels are normally low, and your adipose tissue releases, you release the brake on lipolysis because your insulin from your fat stores. Muscles take up fatty acids and preferentially burn that for energy. So you actually lose weight when you sleep. And then when you are eating and there's glucose, the muscle switches from fat to glucose, and you primarily take up glucose in the muscle to clear your glucose load. Now, when you become metabolically inflexible, then what happens is that you can no longer go back and forth, and you have relative inability to metabolize fatty acids. So when you use up glucose, when you're done with glucose, you essentially end up with, when you use up your glucose stores, you start breaking down protein. And that's part of the biology of sarcopenia that is associated with obesity, insulin resistance, and why sarcopenia is so tightly related to bad outcomes. So there is a lot of work right now going on to try to unravel the metabolic inflexibility. The problem has been that pharmacological attempts to break metabolic inflexibility have all resulted in off-target problems. And so there has not been substantial forward progress. So the best data on metabolic inflexibility and flexibility right now is with exercise, significant exercise. And that's why diet alone doesn't do it. You have to combine diet with exercise. And number two, among the drugs, GLP-1s and SGLT2s seem to work through breaking. Especially the SGLT2s, we have really emerging nice data that by getting rid of the glucose, you're forcing the muscle cells to relearn how to use fat as a source of energy. So that is really tackling the root cause, because that is what drives the metabolic stress. Because if your muscle is only using glucose and protein for energy, the fat has nowhere to go. The fat goes back into the fat store. So you cannot even lose weight if you exercise. Or it goes into the liver, or it goes into the heart. So we know that the heart failure with preserved ejection fraction is associated with increased myocardial fat. We know there's fatty liver disease. And even in chronic kidney disease, we now know there's increased renal fat stores. So there is a systemic lipotoxicity, which is at the root cause of all of these different end organs. And even Alzheimer's disease, which is now being connected with obesity, is related to this lipotoxicity and neuroinflammation.
So the future lies with GLP agonist and
Thank you very much.
SGLT2.
Well, there may be other ways to tackle metabolic activity. This is a very active field, but there are a lot of approaches. But I think the future lies in finding drugs that will affect all of the end organs. You cannot take 3 drugs for blood pressure, 3 for lipids, 3 for your blood sugar. You're now 9 drugs. Then you have to take a PPI to deal with the dyspepsia that the 9 drugs cause. Then you get depressed because you're taking 10 drugs. So you have to take 2 drugs for depression. So now you're on 12. Then you add one metabolic drug for NASH and one antifibrotic, and then the kidney guys come up with some drug. Now you're talking 16, 17 drugs. So as we increase the number of drugs, the incremental value of the drugs becomes less and less. So I think the future is reductionist, which is reducing the number of drugs, but increasing the impact of the drugs on all the end organs. And I think that's probably a good place to stop this webinar.
Yes, because it's almost 10 p.m. and we have a night curfew at midnight, 12 p.m. Only 2 hours for our staff to go back home. Anyway, thank you very much, all the speakers, particularly Professor Arun Sanyal and the ZIFAM company, and we enjoy very much. Dale, could you make a few closing remarks and we'll close this webinar. Thank you very much.
Thank you all. It was a pleasure listening to you all. And I think we had an excellent presentation by Professor Sanyal, and all the speakers had very elegantly presented their data. I'm sure audience would have been enriched by a lovely treat by all these professional speakers. Thank you so much, and good night to all.
Good night and good morning, Arun.
ZIFAM, caring for well-being.